Start. Everyone other can just. Okay. Good evening. I welcome you all on the behalf of IPS West Zone Branch Women's Psychological Health Committee for today's interesting session on psychological and sexual health in early menopause from symptoms to solutions. Our speaker for today is Dr. Ashlesha Bagaria and chairperson is Dr. Khyati Metalia. Let me introduce Dr. Khyati. Can we have the slide of Dr. Khyati, please? Dr. Khyati Metalia has done her DPM and MD in psychiatry. She is the owner of Sakhi Women's Mental Health and Child Guidance Clinic at Ahmedabad. She is co-chairperson, School Mental Health Subcommittee, Indian Psychiatric Society. She is advisor to Public Relations Subcommittee, IPS West Zonal Branch. She is ex-chairperson, ex-advisor on Women's Psychological Health Subcommittee. IPS West Zonal Branch. She is ex-co-chairperson, School Mental Health Subcommittee, Indian Psychiatric Society from 2016 to 2018. She got Young Psychiatrist Award and BPSS Award at national level, as well as many awards in state and zone. She has presented in zonal, national, and international conferences. She has published many chapters in books. She has taken several lectures among various medical professionals and among varied audiences, including teachers, students, and judiciaries. She has done a lot of community work post-earthquake and post-riots in Gujarat, and she is Visharat in Hindustani classical music. So, Khyati ma'am, over to you.
Thank you so much, Nitisha and Neena ma'am as well for giving me the opportunity to be here sharing this session. As we all know, menopause is a heading which always catches attention of everybody because this is the phase of a woman's life where she is disturbed. She may be disturbed psychologically, hormonally, physically, socially, family-wise, and so many ways. And we are having with us Dr. Ashlesha Bagadia to talk over this. Can I have the slide, please, Nitisha? Yeah. So Dr. Ashlesha Bagadia, she is a big name in perinatal psychiatry. She is the co-founder and head of psychotherapy at Green Oaks Initiative Community Mental Health Center in Bangalore. She is the co-founder of a psychotherapy training organization, PARC, based in India. After completing training in psychiatry, she did a fellowship in perinatal psychiatry and women's mental health from University of Toronto, Canada. She is currently the president of South Asian Mass Society, which is a regional chapter of the International Society for Perinatal Mental Health. And we all are fortunate over here to have you, Dr. Ashlesha, ma'am, for presenting your talk on the current topic of managing the early symptoms of menopause. Over to you, Dr. Ashlesha.
Thank you so much. Thank you, Dr. Khyati, and thank you, Dr. Nitisha, for inviting me. And I'm really glad to be here and glad that so many of you have joined so late in the day and also at a time where I know there is a lot of unrest and difficulties at work as well. So thank you for joining. I actually, have been reading up a lot about this since the last few months, especially because there are a lot of new evidence has come up in mental health and menopause in the last decade or so, the work that has been coming up. But I wouldn't mind being interrupted whenever there are any doubts or questions. Because I think the practice of biological management is still not very, not very common in psychiatrists. But it'd be nice to start thinking and maybe hearing from all of you as to how confident you'd be feeling in managing any health symptoms that come up in the menopausal period. So what I thought I'll do today is just go through, like refresh our memory in, trying to understand what actually happens in the perimenopause period, and menopause and postmenopause as well, and have a picture of biologically what is going on for most of these women and what might be concurrently psychologically going on and what are the ways in which we can address this. So it would be nice if we all start thinking about the women that we are already working with who may have mental health symptoms, who may have a primary psychiatric condition. We may also want to think of women who might be caregivers or relatives of our existing patients who may not have a primary psychiatric condition, but may be presenting with some symptoms that could be fitting into the perimenopausal area, and particularly paying attention to the early age group. So early menopause is considered early if it is 40 and before. And in India, especially, we'll find that the incidence of early menopause is slightly higher. So premenopause is, when the hormonal levels are at physiological state. So physiological hormonal levels is, estrogen um, uh, and progesterone are balancing each other out. Progesterone usually gets secreted when there is ovulation happening. And perimenopause is when the hormonal cycle starts changing. So during premenopause, at the normal physiological cycle, estrogen is rising, falling, progesterone is getting released, then not getting released, and that cycle is going on, right? But in perimenopause, what starts happening is the estrogen variability becomes erratic. The progesterone release becomes less frequent because they're having more periods of anovulatory cycle. So they don't have periods. Whenever they don't have a period, there is no ovulation, so progesterone doesn't get released. And there is a gradual decline in testosterone in women anyway, almost from the adulthood. That gradual decline also starts worsening in the perimenopausal period. So what they might be experiencing externally is that there are some physical symptoms, there may be some irritability, periods are still going on, but the regularity has gone down. And menopause is when there is no menstruation for 12 months. Postmenopause is life after full cessation of menstruation. And now we are seeing that women have at least 1/3 of their life in the postmenopause period, where periods have completely stopped. And they no longer have estrogen, progesterone being secreted on a regular basis like it used to. So this is really important to keep in mind when you are thinking of the women that we are going to consider. So like I mentioned, the variability of estrogen increases in the perimenopausal period. And as the variability increases, I think I have yeah. So if you look at this graph, the fluctuation is more regular in the reproductive years. And then in the perimenopause, the fluctuation becomes marked. And in the menopause, both the levels of progesterone and estrogen goes down. So if you look at that part where it says perimenopause, that period is what we are noticing in our women who come with psychological disturbance because of that erratic up and down of the hormones. And testosterone levels are falling gradually. Now, one of the things to also keep in mind is the follicle stimulating hormone. So from perimenopause, especially in early perimenopause, what we are seeing is reduced ovarian sufficiency. So ovaries are reducing the estrogen and testosterone release because there is reduction in the gonadotropin releasing hormone, which is supposed to be stimulating the pituitary. The follicle stimulating hormone levels also get affected. And so there is a primary ovarian insufficiency. Now, this is sometimes used to diagnose perimenopause, but it's not a very reliable marker because FSH levels can be very erratic. And although many people use it to diagnose perimenopause, it's actually not a very reliable marker. So the reason why we psychiatrists have to take care of perimenopausal women and be mindful of them is because estrogen receptors are not just present in one part of the body. They are present in a lot of the parts of the body, and especially in the central nervous system as well. And we know now without a doubt that estrogen enhances serotonergic activity. It facilitates dopaminergic neurotransmission. It also upregulates glutamate receptors. And it also has a lot of neuroprotective and antioxidative effects. So if the estrogen level is falling earlier than it should, then it's going to have an impact at that time when the woman is experiencing this erratic estrogen and lowering of the estrogen. And it's going to have an impact on her leading a longer life without estrogen, which is going to have an impact. Progesterone, its absence also can create problems because one of the derivatives of progesterone, which is allopregnanolone, it inhibits the GABA receptors and it has an antidepressant effect. So the loss of progesterone, the loss of ovulation, the loss of periods can actually also have negative effects for a woman, especially if it starts happening earlier. And testosterone is directly linked to the libido. It may increase, usually if testosterone is present, it has a pathway to increase the dopamine in the central nervous system. And in many situations, it can also be converted to estrogen and leads to a secondary effect of estrogen in the body. So if testosterone is going down, and if it's going down earlier than usual, then that has a ripple effect on the rest of the body as well. So like I mentioned earlier, globally, about 1 in 100 women, so 1% develop menopause under 40. And in India, a couple of studies show that this is slightly higher. And the studies that I have mentioned there, they talk about, the stress factors, the external factors, or the factors that are specific to India, for example, poor nutrition, poverty, reduced education, literacy. They seem to be associate factors that lead to early menopause. I'm not sure how strongly that is backed up by more evidence, but at least some of the studies are saying that there are external factors that can contribute to early menopause. The one evidence that is there without fail is genetic history. So if your mother has had early menopause, or the mother of your patient has had early menopause, then she's more likely to have early menopause as well. And even so, what used to be the age of menopause, it was at around 50 to 55. That age generally has gone down. So now the incidence of women under 45 developing menopause has gone up to 1 in 20. And what we know from a psychological point of view is this transition, that perimenopause period. If they have a longer perimenopause period, that is their most vulnerable time for any mental health symptoms to develop. So the risk of clinical depression is highest during the transition period and in the early menopause period. So if their periods have stopped completely and they are not having any periods at all, that first year is quite vulnerable. So the entire perimenopause period and menopausal period is a vulnerable period for them to be developing mental health symptoms, especially depression. Now, if you think about this age, we are talking about women in their 40s, early 40s. What are the kind of things that might be happening in their life? Many women at that age, especially now, if you look at the current generation, will have children who are sort of in high school, perhaps, or in middle school. They might have older parents that they have to look after. They might have a career that may be reaching its full momentum, right? It's not a start, it's a full momentum. So it's a time where they may have to be giving their full attention to everything. It's different if you think about it psychologically from how a woman might be experiencing the early parenting phase, where there is support, there is understanding that, you are a new mother, you need extra help. But this age where children are in school and parents are growing old, but they're not completely, disabled. So you've not really got like a nursing care or everything sorted. So they have niggling things that need your attention. Your children have things that need your attention. Your career has things that need your attention. So it's a very demanding time for the woman, and her body is perhaps not behaving like it should be behaving. So this is a time where it makes her more vulnerable, because this is a time where she would want her body to be, working at its optimum. And if she's going through early menopause, that can be really, really difficult for her. So the symptoms that we can see, that are sort of designated, that we can understand, that come out of perimenopause and menopausal dysregulation of the hormones that I talked about, can be categorized as physical, psychological, sexual, and urinary. So genitourinary. Now, this is not new for us, but it's really important to put them together, because you may be seeing someone who may be coming to you with the depressive symptoms. So it's important to ask about perimenopause, even in someone who's, say, 39, 40, especially if she's presenting with some atypical symptoms, or she's presenting with symptoms that don't seem to be responding to medication. So the symptoms in blue are things like headache, tinnitus, dry eyes, burning mouth. Now, some of these are because of the estrogen variability, increased variability. Palpitations, night sweats, fatigue, paresthesia. So they have some tingling and pins and needle sensations. Hot flushes, a common one. Irregular periods is another one. Joint and muscle aches. So the tricky part about hot flushes is that unless a woman has had that hot flush, she won't know what is a hot flush. And when there is variability in weather, especially if you are in a hot place, you're going to the AC, you come out, or you're going to the hot kitchen to cook, they may miss those symptoms. But once they recognize it as a hot flush, they recognize that they just started sweating, even though there is no change in weather, and it's like that parasympathetic response, then they are able to sort of and if you ask them, if you're eliciting the symptom, if you ask them, then they're able to tell you, yes, they are starting to have them. Many of the other symptoms can be hard to for them to pin down, especially because they dismiss things like headache. That is just there. I didn't drink enough water, I didn't sleep well. But then if you put it together, you're not sleeping very well. What's happening? You're getting headache as well. Your eyes are dry. Nowadays, we're spending so much time in front of the computer that we can have dry eyes, and we attribute it to the computer. So it's important to see if a lot of these symptoms are coming together, and to consider the possibility of perimenopause if they're all falling in together. The psychological symptoms, even if they're not depressed, if they're not clinically depressed, what can occur as a result of the hormonal changes is low mood, that may or may not meet the criteria of clinical depression. Poor sleep, so there's difficulty falling asleep, there's difficulty staying asleep. It's irregular. Some nights is okay, some nights is bad. But there is this restless sleep, not feeling refreshed when they wake up. Tearfulness, so easily getting overwhelmed and becoming teary. Panic attacks. For some women, this is the first time they're getting a panic attack in the perimenopausal period. And that itself can be quite alarming. And they, interestingly, sometimes attribute it to psychological factors and may or may not link it to changes in their hormones. Of course, anxiety is one of the things. Now they also, because they start developing irritability and memory loss. So especially for someone, if you think about a woman who has to, juggle so many things, if she starts forgetting things, that can add to the stress, that can lead to a vicious cycle of all these other symptoms. And the biggest thing that starts happening is the reduction in confidence. So especially if you think of high functioning women or women who have been managing well, she has just started to get back on track, right? The kids have gone into a kind of a rhythm. They are in middle school or high school, and things are getting sorted there. Everyone is sort of getting settled, and things start falling apart for her. So it starts undermining her confidence, because it makes her feel that she needs to do better. She is not doing well. So a lot of these symptoms can actually lead to reduction in confidence, low self-esteem, and make that listless feeling, I don't feel like doing anything. A big one that happens around this time the reduction in libido, which is linked to the reduced testosterone, can actually lead to relationship difficulties, which at a time where she needs increased support can cause a little bit of a drift in the marital relationship, which is also, kind of uh, sort of brushed under the carpet. We've been married for so long, we don't need to have a very active sexual life. I don't think it's picked up as perimenopausal. And there is a sense of dismissal or relief because she might also start having the genitourinary symptoms. So there is increased vaginal dryness. There is altered genital sensitivity. There is also discomfort in the vaginal area. There might be increased recurrent UTIs because of the dryness. There is urinary urgency, so that again impacts on the self-esteem, confidence, and confidence in being intimate. There is dyspareunia for some women because of the dryness, and there is frequent nocturia. So a lot of these things, there is a psychological impact on the physical symptoms, and there is a physical impact on the psychological symptoms. And so it's important to keep this picture in your mind, because if you just see a few of these, thinking of the age of the woman, it's important to just broaden it out and rule out perimenopause as one of the options. And in early menopause that we're talking about, especially in late 30s, early 40s, consider it as a differential when you see someone presenting with a mood disorder. We often don't think about it. And I'm more and more, especially more recently after listening to people doing more research, more evidence coming out of it, that it is something we do need to keep in mind. Especially because if it is left untreated from a hormone point of view, what we do know is it impacts on fertility. And a lot of women are having, um, sort of delaying their pregnancy. So if they are already going through an early menopause and it's not picked up, then that may be a problem for them. And of course, if it is not treated, if hormone replacement is not considered, then osteoporosis, cardiovascular disease, neurological disease, and a higher risk of premature death are all now being documented as evidence for untreated early menopause. So of course, what do we have to do? We do an assessment, and for us, the main standard for even for gynecologists is primary clinical interview. So making sure you have a comprehensive history and get collateral from the family members as well. Like I mentioned, FSH levels. NICE guidelines says that if you're going to do FSH levels, probably it is indicated for the early menopause rather than 45 years above. But even then, it is not very reliable. You need to have at least 2 FSH levels which have to be high, and they need to be at least 4 to 6 weeks apart. And but even the European guidelines, they all recommend that that should not be the primary treatment. It needs to be linked with presence of perimenopausal symptoms. There are also some screening tools which have been recommended by NICE guidelines. I've never used these screening tools, so I'm not sure how they translate to the Indian system. If anybody here has used it, please let us know. There may be some value in the research area. I know they get used in research and in published papers, but I'm not sure clinically how beneficial it is. One of the things to, of course, keep in mind is how do you differentiate between perimenopausal depression and clinical depression? And one of the, of course, the perimenopausal symptoms are fluctuating. It may not give you a link to a psychologically distressing event. There are more chances of premenstrual exacerbation in perimenopausal depression. Premenstrual exacerbation may or may not be there in clinical depression, but especially if they're depressed, there is no exacerbation in the premenstrual period. It's kind of a sustained low. And in perimenopausal depression, anxiety is worse in the mornings. And in clinical depression, we know that early morning awakening, mood is worse in the mornings. If it is mixed anxiety and depression, this may be a little bit tricky to discern. So then, our clinical judgment becomes more important. Psychomotor retardation is more likely to be seen in clinical depression. In perimenopausal depression, you're going to see irritability. There is bursts of activities followed by apathy. And there are other physical symptoms that will tell you that, like we mentioned earlier, that can be more of a distinguishing factor from clinical depression. One more thing that I think I missed adding here, there is also, especially may not be so much for the early menopausal women, but between the age of 40 to 45 and even up to 47, 48, the risk of suicide seems to be a little bit higher, especially for women when they looked at across age groups between 40 to 45. And this is global data. I'm not sure how strongly it translates to India. I feel India, it may be still in a younger age group. But 40 to 45, the suicide risk seems to be higher if you look at a lifespan of a woman. So especially if you're thinking of perimenopausal women, we have to keep the menopause as one of the options and make sure we address it, because the risk of suicide is going to be high, especially if they're not getting enough relief from the traditional methods of treatment. So then their chances, if they're slightly suicidal, their chances of starting to feel hopeless about treatment, about getting help, are much higher. One of the things to keep in mind in terms of management is the psychosocial risk factors. Like I mentioned earlier, what is going on in the woman's life at this time plays a huge factor, plays a huge role in, even if it is biologically perimenopausal. And as you may, be well aware that every age has a different risk factor, different situation. Another factor that can be happening for some women at this stage is the likelihood of a separation or a divorce. Um, the evidence is showing to us that, especially when the children start growing up, or when the children are about to leave home, or they're about to think of university, if there has been marital discord, then this is a time where women may be considering divorce. So at a time where she might need more support, she is probably exposing herself to less support. And depending on what the environment is, her family of origin may or may not be accepting of her decision to have a divorce. Um, so this is quite a delicate time for a woman, especially if she has psychological risk factors, social discord. Then those things can be affecting some of the women who may need more support. Past history is also very important, especially if there is history of trauma, if there is history of estrangement from family members, and that can tell you that you may need to add additional factors to your management strategy, and apart from just looking at the perimenopause. So you might have to do a combination of managing the depression, psychosocial factors. Sorry. I think there's an echo. If someone can mute themselves, that would be. Can you hear the echo as well? Okay, stop. So the main thing to start thinking about, and the reason why I want us to have this conversation today, is to think about HRT, and it need not be you who's commencing the HRT, but start considering the possibility and expose them to the possibility of considering hormone replacement therapy, especially if they're presenting with depressive symptoms, anxiety symptoms for the first time in their life in this age group. What we know in terms of management. So I have been quite conservative till now. And usually if a woman in her 40s, 50s presents with depression or anxiety, no matter what kind of depression or anxiety it is, I usually give SSRI. And I used to be quite, I must say, not very diligent in asking for perimenopausal symptoms in 40-year-olds. And if they did have hot flushes, if they did have some of the physical symptoms, what we know now as evidence is SSRIs can reduce some of the physical symptoms also of perimenopause. But when they were given HRT instead, they responded much better to it. And what NICE is now started to say, as in terms of recommendations, is that there is no clear evidence for SSRIs or SNRIs to ease the low mood in menopausal women who have not been diagnosed with depression. So if there is not clinical depression, and if they have all the other symptoms that meet the criteria for menopause or perimenopause, then HRT is actually suggested as the first line of management. The the recommendation is to have a combination of both an antidepressant and hormone replacement therapy. Uh, the worry also is that if we only give SSRIs, or if you only give an antidepressant or an anti-anxiety medication, we are also exposing them to side effects, which usually they are able to balance out because we know the benefit outweighs the risks. But in this woman, especially if they are having symptoms like low libido, genitourinary symptoms, and low self-esteem, due to how their body is responding or not responding, the side effects which are of a partially effective antidepressant may not be very welcome to them, may actually worsen the perimenopausal symptoms. So whenever I look at this slide, I'm thinking, oh my God, I don't really want to know all of these things. So what I usually do, at least I've done when I started being more cognizant of this, is to work collaboratively with my gynecology friends. And I found that my patients are also more receptive to that. They're much happier me working together with a OB-GYNEC, so that we are, making sure that they have the best care. But I thought I'll just give you an overview of the different kinds of HRT treatment. If someone has had an hysterectomy, then they only need estrogen. We don't have to worry about the risk of endometrial cancer. And if someone has still got their periods ongoing, but they're starting to have symptoms of menopause, they can go on the cyclical HRT, which are of two types. One is a monthly HRT, which is a daily estrogen, and progesterone is given at the end of the menstrual cycle for 14 days. The other option, which it seems to be more popular amongst OB-GYNs, is the 3-monthly HRT. So they give daily estrogen and progesterone for 14 days, every 13 weeks. And this is more sort of beneficial for those with irregular periods. And the reason why they do this in 3 months is so that they know that, okay, periods are still going on, and they get an idea that when periods are stopping naturally. For postmenopausal women, both estrogen and progesterone are given daily without a break. The common ones that women tend to prefer is the patch of the estrogen, and progesterone can be given even as a Mirena coil, which is just there for 5 years. There are some contraindications to HRT. If there is a current, past, or suspected breast cancer history. Now, I'll come back to that because there are some exceptions to it. If they have had or they have an active estrogen receptor positive cancer, if they have some unexplained vaginal bleeding, which is not linked to periods, so they have uninvestigated, say, cervical cancer risk or positive pap smear, then that needs to be investigated, and HRT can't be commenced, of course. If they have untreated endometrial hyperplasia, if they have an active thromboembolic disease, so clotting conditions worsen with estrogen, or risk acute MI, pregnancy is another contraindication. Now, coming back to cancer of the breast, many guidelines are beginning to say that even HRT, the reason why it was not very favorable in the past is because it was linked to a high risk of cancer of the breast. And there was a landmark study that was done, and that from that study it came up. So now they've relooked at that study, and they've seen that actually the risk of breast cancer, the benefit of the HRT outweighs that risk. And at least for 5 years, if you give HRT, the risk doesn't go up. So there is a possibility of the risk coming up after 5 years of continuous HRT. But even that risk, because the treatment in advances in breast cancer treatment have advanced so much that the benefits of the HRT, especially for many women, even when they have a risk of breast cancer, they are choosing to take hormone replacement therapy, because they feel like, okay, if I develop a lump or if there is a risk of breast cancer, then I will get the treatment for it, and I would rather have that treatment than be left with all the other risk factors of not taking HRT. So it is something that, again, I would leave in the hands of the gynecologist because they deal with it a lot more. But it is not an absolute contraindication, is what I'm being told by my colleagues and what the evidence is suggesting. So that was hormone replacement. And apart from that, there's a whole lot of things we need to be thinking about for our women in the perimenopausal period, and especially in early perimenopausal, early menopause. So it's important, of course, for our all our women and all our patients, we look at their vitamin levels. But especially for these women, the vitamin D and calcium needs to be supplemented. And there is now increasing evidence, that even in India, we seem to have a high level of vitamin D deficiency despite the sun, because apparently the absorption actually goes down in perimenopausal women as well. So it's important for them to have that vitamin D and calcium supplements. The diet also needs to be adjusted, because that starts addressing some of the other symptoms, nutritional deficiencies. So high protein and high fiber, low carb diet is recommended. Increasing foods that are rich in phytoestrogens, such as lentils, kidney beans, soybeans, millets. Increasing the dry fruits, nuts, and seeds for neuroprotective factors. It's really important. And this is kind of, common knowledge now, but it's especially so for women in this age group. Exercise also, there are recommendations that are actually specifically being given to perimenopausal women. So if there is weight gain, bloating, then there is a recommendation to at least have 60 minutes to prevent 60 minutes of exercise per day for at least 4 to 5 days a week. But even otherwise, 30 minutes to keep that mood symptoms at bay, to reduce the depressive symptoms, to cause behavior activation if they're going through depression. A big one is weights or strength training. All women from the age of 40, maybe earlier they're more likely to nowadays, but there is enough evidence now to say strength training, increase the strength of the muscles, is recommended now for all women, which at least twice a week, to build muscle, to improve recovery, and to increase the bone density as well. Balance and posture related exercises. So as the women grow older, they're more likely to do maybe yoga and Pilates or whatever they have access to, which is also very helpful, or physiotherapy if they're post-injury. But it's really important for perimenopausal women, because then their chances of falls reduces, their chances of recovery after fall improves. Kegel exercises for strengthening pelvic floor, breathing and reflective practice to improve mental well-being, and to strengthen the respiratory system. So now I've started sort of giving this as advice as well, prescription of exercise as well, especially for perimenopausal women. And it's helpful if I see a lot of perinatal women when their, pelvic floor is already a little bit weakened. So this is a time when I tell them, start doing these exercises now itself, whatever you can, so that it becomes a habit as you enter your late 30s and early 40s. Psychotherapy and psychological interventions are very important. And in fact, sometimes that may be all they'll be willing to do. Nothing else, especially if they're not willing to take any medication. And if they have mild symptoms and the depressive symptoms are not very severe, sometimes if they're severe also, we know how hard it is for them to maintain medication. A big one is to address their relationship with their husbands. If the sexual activity has reduced, to notice what is the problem, to elicit the problem, to see if they can use, lubricants, sexual aids to improve their sexual activity, and to have some education around what might be happening there for the woman. And one of the things that can often be a myth is that, it's the husband who wants to have sex and the woman doesn't want to have sex. And that's not entirely true, as we all might have seen in our patients. Actually, if a lot of these factors are addressed, and if they get the right kind of help, then even the woman's interest, or at least satisfaction with intimacy, improves, and then her general well-being, her confidence also comes up. There is also evidence to have targeted CBT for hot flushes, for night sweats, panic attacks, just like how panic attacks can have a flow of CBT, how it addresses, it can also address hot flushes. Because when a woman has a hot flush or wakes up with night sweats, there are a lot of psychological things that she experiences. There is embarrassment, there is fear of being judged. So all of that can be actually managed quite well with focused CBT, and that is shown to improve their response to it. That is shown to improve their way of managing it and navigating this transition period where they're most likely to experience these symptoms. CBT for insomnia again has well established evidence. A big one is also looking at what are the psychosocial risk factors in the family. If there is conflict, if there is estrangement, if there is discord, and that needs to be addressed either by education or targeted family therapy. There are also possibilities of them having lost someone, because if there is illness or morbidity in family members, older family members, then they may need specific targeted therapy to address that. A big one that can really help for most of us, I think, and this is a slide I usually even add to my talk when I talk to healthcare professionals, and their mental health. And right now, as doctors, we are all experiencing so much of distress that we all need to start thinking of how to look after our mental health, especially young residents and young doctors. So for women in the perimenopausal age group, when they can't really do much about that changing biological clock. Physiologically, there is only so much. They may take hormone replacement, they may take antidepressant, but some of the other things that can actually they can start doing straight away, is to do something that builds the neuroplasticity, improves the neuroprotective factor in the brain. And we know that activities that are social, cognitive, and physical, and if they're at the same time, so playing a sport, for example, and even more so, meeting a friend and saying, come, let's go play badminton. So you are socializing, you are actually thinking, using your brain, okay, how am I going to hit the shuttle? You are also doing something physical, uh, dancing, or even going for a walk with friends, or anything that makes you do these physical activities together in a social setting, can really help improve the neuroplasticity and reduce the distress and irritability that comes with this perimenopausal period. And we know that activities such as volunteering, doing community service, having some kind of connection with the society can be another thing that can help them. Spending time with family, but also taking time out from family. That is something that, and I know, people say things like me time, but it need not be that they have to be alone. They can go and do something else, but they don't always have to do something for the family. Taking time away within the city itself, or just going and staying with family members. As women grow older, I know that, this used to be a practice. I don't know if it is still there in many, but I'm seeing it less and less in my patients, where, they would go and stay with in their mother's house for holidays. And now the kids are so busy during holidays, as they grow older, that going and staying with mother becomes less and less frequent. And this age group, especially in the 40s and 50s, it's even less, unless the parents need some physical help or something like that. So that taking time off from their routine is become less, unless they're going for a holiday. So it might be nice for the woman to go and stay with a friend, stay with her mother, take that break, go and stay, even if she's not going away from the city, and have that activity built in as well. Another thing that can happen, and fatigue is one of the symptoms in the perimenopausal period. So what can easily happen is that they can let their battery run down completely in all the areas. So it's important to help them think that, keep your battery running at least in one area, whichever of these areas. Don't let everything get depleted. And it's important for them to think. This is a time when they start thinking, what is happening to my life? What am I doing? Where am I? What am I running towards? So it's good for them to do this in a more reflective way rather than a judgmental way, and retain the energy for the things that give them more meaning and are more mindful for them. Of course, we all need to do this, monitor media use, especially during bedtime. And what I also tell them is that it doesn't mean that you have to switch off everything and get bored. That would be nice if you could do it, but it's very hard to do. But you don't just doom scroll or scroll through the internet. Use a purple, go to the internet with a purpose. I'm going to binge watch this show for the next hour, or I'm going to, for the next 2 hours, just watch this movie. So you go purposefully towards a program rather than just letting the internet tell you what to watch and watching reels after reels. Of course, this is another time also to monitor the substance intake. We know that increased use of alcohol, especially during the perimenopausal period, can worsen the symptoms. So I'll just end with this case example. Suma is a 41-year-old professional woman. She was married for 18 years and has a 14-year-old daughter. The husband has always been very busy and aloof, but probably was more so in the last few years. Her parents lived far away, but her father had recently passed away following a 2-year battle with cancer, following which a mother was living with her brother. And she had a history of subclinical anxiety since her postnatal period about 14 years ago. She had a little bit of anxiety around that time. And 3 years ago, around COVID, she had mild depression. She had taken an SSRI, had felt some benefit. She took it for 3 months, and then had 1 year of counseling with one of the local counselors. I don't think it was a clinical psychologist, but she felt it was okay. She seemed like, she said it was beneficial to some effect. But her main presentation now was with mood swings, irritability, about 6 months after her father's demise. Her periods had become irregular, sleep was disturbed, and she said she had no time to exercise or look after her nutrition. She was just, on a roll looking after her work and house and daughter and all of that. And this was also a time that all her usual friends group were also very busy. So they would meet sporadically, but the regular meetings that used to happen in earlier years had gone down. She was commenced on desvenlafaxine along with HRT. And so this was in collaboration with the obstetrician. The obstetrician said this is actually a good time to trial it. And so one of the first things that improved for her, which she hadn't even thought of as a problem, because she thought that, this sleeping a little late after I finish all my work, then getting up early because I have to pack food and is fine. But when she started sleeping better, that was the first thing she noticed. And she really started feeling more energized. She then engaged better with the psychologist. Then she felt that the counseling that she had got before, she may not have really spent much time, talked much about it. It had been a little apathetic. She was also able to engage in grief counseling with the therapist and talk about the loss of her father, relationship with her father, which had been tumultuous, but it had left a big loss for her. And because she was also feeling better, her self-esteem improved, and she was able to have a better engagement with her husband. She started some evening walks with friends and was starting to cook together with her daughter. So I'll just end on this note and open to any questions, comments. Over to you guys.
Thank you so much, Dr. Ashlesha. That was an excellent presentation. You included all the causes, the symptomatology, and the management very beautifully. Especially, I like that thing, what you said, that when you are using the internet, use it purposefully and don't just scroll it without any, because that is something which everybody does. Most of us do, not only the
I
patients,
also
but
do it.
even
Yeah,
us.
yeah. Yeah.
Yeah. And yeah, so first we'll move on to the questions from Dr. Radhika. For how long can SSRIs be used?
So when we are using SSRIs, we still follow the same protocol that we would follow for depression. I would say that, I mean, at least the guidelines are saying that if they have a pre-existing, like this woman, for example, for Suma, because there was a previous history of mild depression, you can perhaps give her at least for 3 to 6 months and see concurrent with the HRT and see if that benefit is there. And if the depressive symptoms have reduced, but the perimenopausal symptoms are continuing, or they usually will come down as well because of you're giving HRT, you can actually withdraw the SSRI gradually after 3 to 6 months.
Okay. Question from Dr. Manisha Mahajan. Ma'am, what about perception of women towards sexual functions?
Yeah, it's a good question. I mean, it's often not even brought up as a symptom, right? It's kind of dismissed, ki, haan, I'm not interested, or this is not something that I need to address. So there are different responses. One is that when you ask them, there is they will tell you that they're not very active. They might be embarrassed that there is dyspareunia, vaginal dryness. But if you explain that it is because of the hormones, and if with treatment it will get better, some of them are likely to address it. Some of them don't want to. They want to just let it be. They're quite happy with by then many people, especially if they have come to the late 40s, husband and wife have started sleeping in different rooms. They've kind of accepted they're not going to have any more sexual activity. Um, so it depends. Some of them don't want to address it, but if they naturally start feeling better, then they may move towards it again. If they have a reasonably good relationship with their husband, but they've just started drifting apart in terms of sexual intimacy, if you address it, then they're actually quite happy with the sexual function coming back in their relationship. If their relationship has not been very good, then they're not very keen to bring it back. So addressing the family situation, addressing the relationship also helps.
Very true. From Dr. Radhika again, how often do you see male menopause?
I haven't, but it's definitely begin to getting written about. It's not a unheard of thing, and at least they are very less likely to come to a female psychiatrist. So
Psychiatrist.
I have not seen anyone, but I do, because I end up seeing families a lot, and I can sort of, see that there is a transition that the man is going through that is affecting the entire family. And often it is written off as, mid-age crisis or midlife crisis. But there might be some merit to checking their hormone levels and see if there's some male menopause going on.
Okay, now a couple of questions from me, Dr. Ashlesha. Very good to know that you are collaborating with your gynec friend and giving SSRIs, and she's giving HRT. So ultimately, the patient is being benefited. Now, practically, I have seen like not many gynecologists collaborate like this with psychiatrists. So either the patient ends up with only the psychiatrist taking SSRIs, or only the gynecologist who gives HRT and says, like, now you did not go to a psychiatrist because this will take care of everything. So, what is your observation about that, or your views on that? That only HRT is being given, and there are some mood symptoms as well, although no history of depression. How much does it work?
So if they have just the low mood, irritability, then there is definite improvement in that with only HRT. But I feel like if the gynecologist is treating uh, only biologically, I think the benefit of seeing a psychiatrist is that some of the psychosocial factors get taken
Yeah.
care of, which a gynecologist may or may not be able to address. So the risk of not getting an SSRI and losing out on the SSRI might not be so much, especially if they don't have clinical depression. But the benefit of having other factors addressed will be lost. Also, if they are at risk of developing clinical depression, or they are sort of maybe not at the mild end, but at a severe end, then that may get missed by the gynecologist. right? So I feel like collaboration I will say, was difficult initially, but we've been doing a lot of work with gynecologists. Um, and especially in the last few years, we have been training gynecologists in perinatal mental health. We often present to gynecology conferences and have pre-conference workshops in gynecology conference. More, I mean, I've done more of the perinatal part, training them there. And more gynecologists now are approaching us to teach them counseling skills also. Because we know that many women, if the gynecologists tell them, go see a psychiatrist, they don't want to go. So they are like, okay, we'll only counsel them, tell us what to do. So at least if they start doing, that might be good. But as long as they get some proper training for it. So it is happening very slowly, you know, dheere dheere it's happening, but definitely there is some benefit. So if you get a chance to present to gynecologists or, go to a gynecology conference and submit something there, I think it's important for us to infiltrate their world a little bit,
Yeah,
because ultimately it will be a better outcome for their patients.
true.
And we are not taking away their patients from them. We're talking about collaborative care. So I'm
Yeah.
hoping that will help them see that this is beneficial.
Okay, and when the patients come to us with some psychological symptoms but no history of prior psychiatric disorder, then should we like give a trial initially of art medicines plus counseling, or HRT plus psychotropics would be always better?
So I used to think not even psychotropic. I would start with psychological counseling. That was my traditional thinking, right? Like I am a little conservative in using psychotropics anyway. But more and more evidence is suggesting that first of all, you have to screen for perimenopausal symptoms. If there are perimenopausal symptoms, so if they're just presenting with what we can say, okay, it is purely psychological or psychiatric, and there are no other perimenopausal symptoms, then SSRI and psychological treatment is beneficial. But if you're eliciting some perimenopausal symptoms, then you must consider HRT along with SSRI. I think that is the overwhelming evidence that is coming up more and more.
Okay, okay. And question from Dr. Manisha. There must be, I think this is in continuation to the earlier question. Like there must be depressive part as we heard today. Because of that, she may have lost interest in sexual activity. I think this is a comment, sort of.
Sorry, can you repeat that?
Yeah, there must
There must
be
be depressive.
depressive part as we heard today. Because of that, she may have lost interest in sexual activity.
Yes, so the psychological symptoms can be one of the reason for reduction in libido. But what we also know is in the perimenopausal period, the reduction in testosterone that is happening gradually, that also contributes to reduction in libido.
Okay.
And there is also all these genitourinary symptoms, vaginal dryness. So even if the libido may not be fully reduced for some women, the local difficulties may make her lose interest, right? So it may not be only because of depression, it's also because of the genitourinary symptoms that she may not be keen to have sexual activity.
Yeah. Nitisha, tell me when to stop. I'll go on. There is a comment from a gynecologist.
Oh, good.
Yeah, Dr. Hima Bindu Banwal. I am a gynecologist, ma'am, and I agree collaboration is important. And I feel that very few or rarely a psychiatrist gives psychological counseling or treatment.
I
Yeah.
agree. I agree absolutely. And that is another thing also we are trying to change. I mean, what I would think though is that many psychiatrists have either they have a psychologist in their clinic or in their department, or access to counselors, which they are often working very closely with. So their access to therapists might be more, but that may not be true in many settings. Many settings, I know that. So we have also started working with IVF centers where we are training people to do counseling in IVF clinics because they are not trained as well. So many gynecologists are linked to psychologists as well. So we know that they are. And of course, you know, it would be good if psychiatrists collaborate with psychologists, gynecologists collaborate with psychiatrists, and we all kind of work together. And that would be very helpful.
Yeah,
So
there is a further question or a comment. Why don't psychiatrists do any objective scoring and advice counseling? They refer to psychologists when patients are not satisfied.
yeah. So I'm not a very big fan of the scoring tests unless they are done together. Like if you just give like a rating scale to the patient and they have to fill it out, they may fill it out. You may get some score, and then especially in perinatal period, you know, we use the Edinburgh postnatal depression scale, or we use the Wooley's questionnaire. But sometimes it may not be enough. Actually, regular engagement might be helpful, and actually, it really depends on the clinical setting of the psychiatrist, clinical setting of the gynecologist. Many gynecologists tell me that they want to do the counseling, but they just don't have the time, or they, you know, they get pulled off by for a delivery. The same thing might happen to a busy psychiatric clinic as well. And we know, you know, that not all psychologists are competent in managing all conditions. There is a
Yeah.
whole range of therapists out there, and only the clinical psychologists have some regulation. So I think what I sort of take solace in is that our patient population has become very savvy. So they seem to be they know whom to go to. They are like, okay, this is not helpful, I will go find someone that is helping me. So ultimately, more and more patients are able to say, I don't want to see this one, I want to see this one because I connect better. And so they will filter out the right people, whether
Yeah,
we are able to provide care or not.
very true. Now, an interesting question.
Sorry to interrupt. I know Ashlisha ma'am is at present at Australia and it's very late there. So I
It's
think
okay, it's
we
okay. I
can
can take one more
wrap
question.
it up now here. I'll
Yes.
now, Pallavi?
Okay,
Yeah.
so the last question will end
Okay.
up with,
Okay,
Yes,
yeah,
okay.
yes, please.
are there any studies on perimenopause women and ADHD flare-up? Very interesting.
Yeah,
Very
it's a
nice
very
question.
interesting. I think the ADHD studies are just beginning to emerge. I don't, to be honest, I don't know, especially in India, I'm not sure. But I know that there is some emerging evidence on adult ADHD in women. I'm not sure if it is linked to perimenopause. Maybe I will actually go look it up myself and see. So I don't actually know an answer to your question. That's a good question, actually.
It's a very good question.
So I'd like to make a comment.
Hi, Darpan.
Hi, hello everyone. So first of all, it's an excellent presentation by Dr. Ashlesha. She's brought out the topic so sensitively and with all her expertise, and great sharing by Dr. Khyati. And
Thank you,
I just
Darpan.
want to congratulate Nitisha Oza as a member of the IPS West Zone Women Psychological Health Committee, and me being the chair of the committee. It's a big honor for me to appreciate the initiative of Nitisha, and she's done a very good job by collaborating with all of you all and getting you all here. And just one comment also I'd like to add, Dr. Ashlesha, is that I was just wondering whether metabolic factors in women, and especially looking at diabetes, hypertension, and coronary artery disease in women progressing towards transitioning from a perimenopause period to early menopause. So I think some literature highlights that maybe we should also focus on the medical comorbidities and help to identify and treat these general medical conditions as well, which can link to overall well-being in their mental health as well as
Absolutely.
psychosexual health functioning. So thank you very much. And with that, I just passed on to Pallavi and Dr. Nitisha. Please continue.
Yeah,
Thank
Pallavi,
you.
we
Yes,
can have the
please.
vote of thanks.
Thank you, Dr. Nitisha. So, hello everyone. I'm Dr. Pallavi from Goa. I take this opportunity to thank our IPS West Zone President, ma'am, our honorary secretary. Special thank to our speaker for making time from down under. We really appreciate it, Dr. Ashlesha. We really thank our chairperson, Dr. Khyati, for taking all the questions and making time for all the questions. We of course thank our member, Dr. Nitisha Oza. Special thank you for all the audience who joined today, including our IPS National Treasurer, Dr. Alim Siddiqui, and he was there throughout this session. And we also had a very interesting mix of audience today, including gynecologists. So, first of all, a round of applause for our speaker, chairperson, and organizers, because we had more than 60 participants today on a busy working Wednesday. So that's really appreciable. With this vote of thanks, special vote of thanks for our IT tech support team as well. The whole session is recorded and it will be uploaded on YouTube. The link will be provided for all those who need it. Okay. Thank you. Thank you very much, Dr. Nisha. Thank you, Dr. Ashlesha. Thank you, Dr. Khyati. Thank you, Dr. Darpan.
Thank you.
Thank you, Dr. Pallavi.
Really nice to see you.
Great session and very, very, very great program. And thanks to all the audience also. And thanks, Pallavi. Right.
Thank
Thank you so much
Good
for
night,
having me.
everybody.
Bye.
Thank you,
Thank you,
Ashley.
Dr.
Good
Ashlesha.
night. Thank
Yeah,
you.
bye-bye.
Thanks
Good
a lot.
Bye.
Good
Bye,
night.
I think I
Pallavi.
couldn't catch up with you because of your this time zone thing.
It's okay. You can message me anytime.
Definitely.
Bye.
Good to
Bye.
see you again.
Yes, you too. Thank
Good
you,
night.
everyone.
Good
Bye.
night. Good night.
Bye.
Bye.
It was wonderful, ma'am.
Thank you, Nisha.
Really loved it.
I was a little, I couldn't see the clock, so I was thinking, okay, I hope I'm not running out of time, but
I would have heard you for hours and hours today.
heard.
It's very informative. Very nice. Thank you, Khyati, ma'am.
Thank
Looking
you
Thank
so
lovely
you.
in a
much.
sari today.
I'm having some deja vu, like coming back to my own subcommittee.
Yeah.
Indeed.
This
Indeed.
was started like by Monali and me. I think 3 years back, and 3 years like I was over here,
Yeah.
and now I've moved to another